Acute rupture of an atherosclerotic plaque in a coronary artery triggers clot formation, resulting in sudden partial or complete occlusion of the vessel lumen. Myocardium supplied by such an occluded artery will become acutely ischemic or necrotic. Pathologically, persistent complete occlusion of a coronary artery may ultimately result in infarction of the entire thickness of the region of myocardium it supplies. In contrast with partial occlusion, ischemia is primarily focused on the subendocardial region of the affected myocardial wall, and if infarction develops in this situation, it tends to be localized to the subendocardium. Patients presenting acutely unwell secondary to compromised myocardial blood supply are said to be suffering from an acute coronary syndrome. Based on clinical findings, ECG abnormalities, and blood test analysis, acute coronary syndromes can be divided into three categories: ST elevation MI, non-ST elevation MI, and unstable angina, which, as you will now learn, broadly correlate with the underlying pathological findings we've just outlined. The ECG plays a central role in, first of all, identifying patients with an acute coronary syndrome, and in subsequently allocating them to a particular category of ACS. The latter, in turn, is the main factor in determining their treatment. The diagnosis and classification of ACS is a challenging area. Remember, we are essentially trying to make a histological diagnosis, myocardial ischemia or necrosis, using a combination of patient history, blood markers, and surface electrical recordings, the ECG, all of which have major limitations. The ECG is an essential tool in the diagnosis and classification of ACS, but its limitations are legion and arise for several reasons. Firstly, many of the ECG changes of ACS are present as a normal variant on the ECGs of a proportion of the population. Secondly, many of the ECG changes of ACS are not specific and are seen in a variety of conditions unrelated to coronary artery thrombosis. Also, the standard 12-lead ECG has a poor view of several anatomical regions of the heart. It is possible for an initial ECG to appear completely normal in a person suffering an acute MI. And finally, ECG changes may persist following resolution of an ACS. While this generally has no consequences for the patient, it makes the interpretation of ECGs at subsequent presentations difficult. For these and other reasons, the ECG is always interpreted in clinical context, and when available, old ECGs should always be reviewed. Experience is king in this area, but you have to start somewhere, and the following videos give you a description of the ECG changes of acute coronary syndrome.